Hello, and welcome to the third session of A Journey Through the Psychedelic Revival, sponsored by Penn Nursing. If you attended the first session, you may remember me. My name is Kayla Baker. I'm a second-year PhD student here at Penn Nursing. Before coming to this PhD program, I worked as an oncology nurse. And because of my experiences as a nurse, learning about research on how psychedelics help people with cancer really inspired me to take an interest in this evolving field. I know that, like many of you here tonight, I hope to use my professional skills and training to further understand the potential of psychedelic-assisted therapies. I hope this session is an opportunity for all of us to become more informed on the current state of psychedelic medicines with tonight's talk on neuroscience and pharmacology. I would like to take a brief moment to thank our School of Nursing Dean, Dr. Antonia Villarruel, for supporting this series. In addition to the Dean support, we have a hardworking team operating behind the scenes to make this event happen. When asked about sharing a thank you, a shout out to our team, they were very modest and they were uncomfortable with the recognition, but the reality is we wouldn't be here tonight without their efforts. So thank you to our team for their dedication. I do just want to talk briefly about two housekeeping items. One is that we know people have been having some tech issues. Apologies. I know how frustrating it can be. A few suggestions. If you have a bad connection, please try closing out any extra browsers or other programs that are running on your computer. We do find that this platform, the BlueJeans platform, works best on Google Chrome if you're using a web browser. And lastly, if you know someone who cannot log into the session, or if you get kicked out of the session and you can't log back in with the link, just try and re-register to get a new registration link. If you continue to have any tech issues, at the bottom of the event email, there is the BlueJeans tech support link, so please try and contact them directly. Our second housekeeping item is that if you're interested in receiving nursing continuing education credits, we'll post the link for the evaluation in the chat near the end of the session. So please keep an eye out for the evaluation. We will post it in the chat before the session is over. The deadline for submitting for credit is this Sunday night, February 20th at midnight. And then the certificate will be sent to you via email by April 12th at the conclusion of the session. And if you have any other questions, of course, feel free to put them in the chat and our team will be monitoring. You're in for another thought-provoking and engaging journey. We know that the information learned here is only as valuable as the possibility it has to help someone. And in my opinion, that is the real promise of psychedelic-assisted therapies. And that's why we start each session with a short video as a way to humanize and personalize this type of therapy, by hearing about the experience of somebody who has been helped by psychedelic-assisted therapy. Tonight, we're going to hear Abigail's story. After the video, I'll introduce our speaker, Dr. Ben Malcolm. He'll talk for about 45 minutes, and we'll have time for Q&A. Just a note, please use the Q&A function for questions that you have for Dr. Malcolm rather than the chat. In the Q&A function, you can like questions if you had a similar question, so that will help us prioritize questions for Dr. Malcolm in the Q&A. If you have other comments, you can feel free to put those in the chat. Also, we have been saving questions from previous sessions that we think would be really good for Dr. Malcolm to answer, questions related to pharmacology. So you might hear a question that has been asked in a previous session. And now for our video.
My name is Abigail Rockett. I am a mother, a model, and I've benefited from using psychedelics in plant medicine.
I'm from Michigan. Mom and dad split around 10. I grew up in a predominantly Black community. People didn't understand a biracial person where I'm from. And then I went to a predominantly white high school. That was confusing too. I just never felt accepted, I guess. But that difference took me into modeling. Moving to New York, that changed everything.
And then that's when I started getting sick too. I was depressed. I wasn't feeling. Because I was just masking the pain. I wasn't letting anything come up. With drugs, drinking, I was sleeping 20 hours a day. I didn't even feel like I slept when I woke up. That's how bad it was. And I'm like, I need to change. I need to put my foot down. It was hard. It was really hard. I had to sit with myself. I went somewhere else. I opened up a little bit about my trauma, a little bit, the tiniest taste of it, but I ran from it. I did a little bit of integration work, and things changed ever so slightly. But the thing is, it's like I would just continue doing the things that were unaligned with who I am. I didn't fully go through the motions of what I needed to go through. That's, you're really getting to the root of things. This was the real surgery to my soul. I came home, and things started changing. And depression went away. I stopped drinking, stopped the cocaine, and it was so liberating facing every single dark moment in my life. The journey and the medicine, that's not the difficult part. The after, that's what's so important. You have to take the time and really sit with yourself and figure out what your lessons are and apply them. Applying them is the most important thing. I'm still doing the work. I do this for the collective, When we heal ourselves, we heal the world. So it takes one person at a time. It's really beautiful. And it has been life-changing for me.
Thank you, Abigail, for sharing your life-changing story with us. I love that you draw on the importance of intention and integration. And of course, psychedelic substances aren't a magic bullet, but they can really catalyze the path of healing. I mentioned my own aspirations for bringing my professional skills to the world of psychedelic research and practice. And our speaker tonight, Dr. Ben Malcolm, has shown how that can be done. While Dr. Malcolm has quite a resume, including a master's in public health and a doctorate in pharmacology, he has further advanced his practice as a pharmacist by becoming an expert on psychedelics, furthering the reach of psychedelic medicines through his consultation and educational services. You can see Dr. Malcolm's full bio on the registration website. As you listen to tonight's presentation, please keep in mind that the information shared is for educational purposes only. Penn Nursing and the speakers in this learning series do not endorse or encourage the use of illegal substances. And without further ado, welcome, Dr. Malcolm. Thank you for taking the time out of your busy schedule to share your expert knowledge with us tonight.
Thank you so much, Kayla. It's so wonderful to be here. And, just a huge thank you to you, Penn Nursing, for putting this series together and for showing stories like Abigail's, really, because I personally believe that this is the way that people are going to really understand what psychedelics can do. But my job here tonight is to talk to you a lot more about kind of pharmacology and nuts and bolts of what these substances are, or at least our modern day understanding of what they are. I'm going to go ahead and share some slides with you. Hopefully you'll be able to see them now. And away we go. So Kayla went over some of the disclosures and the disclaimers. For myself personally, I am a psychopharmacology consultant, and I do that through my website, and I have a variety of relationships there. Our objectives for this presentation are fourfold. I want to begin with sort of a big picture introduction to the neurobiology of psychedelics. I'm going to talk about the pharmacology of kind of three of the clinical frontrunners, ketamine or S-ketamine being FDA approved already, and psilocybin and MDMA in phase 2 and phase 3 trials, respectively, with some pretty good data coming out of it and probably expected approvals in the next few years. With that pharmacologic overview, I'm going to kind of outline some of the potential drug interactions and contraindications to psychedelic use. And we'll finish with a little bit of comparative pharmacology and summarizing the clinical data that is out there to date. So maybe you went to the first couple sessions in this series, or you have a pretty solid idea of what psychedelics are. But there's many different words or terms out there that could describe what a psychedelic is. And, some of the earlier ones were limited to what an observer saw in someone else having a psychedelic experience. And then, terms like hallucinogen, which is kind of pointed and one-dimensional as far as their effects. A psychedelic is a very umbrella term. And then there's some more specific types of terms out there that relate to the kind of subjective states that different types of psychedelics can elicit. So you have things like entheogen, to cultivate the divine within, and perhaps this is associated with the mystical experience. When I think of the mystical experience in modern day research, I think of psilocybin. Enactogen, to touch within, or maybe empathogen is another word out there. I tend to think of phenethylamine psychedelics like MDMA. And then, dissociative anesthetics like ketamine, I believe, do fit the umbrella term psychedelic, and that one probably is most associated with that type of substance. But what I'm really excited to share in this section is the sort of new understanding of psychedelics as psychoplastogens or neuroplastogens. So starting to describe psychedelics not from the perspective of a subjective experience, but from the perspective of their neurobiological types of effects. What do psychedelics do? Lots of different things in many different people, and this is probably why if you talk to 100 people, they're going to tell you 100 different things about psychedelics. Obviously, they create a non-ordinary state of consciousness. You hear a lot about their spiritual qualities. They increase emotional vulnerability and suggestibility. So this is probably a really important piece for thinking about the environments that people suggest or ingest them in and the safety of them. They amplify internal and external phenomena. They expand awareness and the emotional range. They change the meaning of our perceptions. And this is probably a really important thing for seeing our old problems in a new light. They modulate sensory information. They generate somatic effects. So much you hear about psychedelics as being a mental or a psychological type of experience, but I think the psychedelic experience, especially serotonergic psychedelics like MDMA or psilocybin, are kind of full body types of experiences. The experiences elicited by psychedelics tend to carry a lot of personal meaning and significance. And finally, they rapidly and persistently reduce symptoms of several psychiatric illnesses when ingested with a model of accompanied therapeutic support. So how psychedelics are being researched in the modern age are from a number of different angles or perspectives, and oftentimes experiments will combine some of these things. They'll look at some of the pharmacology along with neuroimaging, or maybe try to correlate neuroimaging with phenomenology and then the associations with the clinical outcomes. So I personally really appreciate this because we're getting a picture of what psychedelics do from many different angles that can then be linked together to create a more holistic understanding of the substances. All right, let's dive into the neurobiology a little bit. Serotonergic psychedelics primarily work via stimulation of serotonin receptors, and specifically a subtype of serotonin receptors known as the serotonin 2A receptor, whereas ketamine is not a serotonergic psychedelic. It's a dissociative anesthetic, and it works primarily through non-competitive inhibition of a type of glutamate receptor called the NMDA receptor. We think that psychedelics are able to promote neurogenesis and synaptogenesis. So neurogenesis meaning the generation of new neurons, and synaptogenesis meaning the generation of new connections between existing neurons in key regions of the brain that are linked to mood disorders, and particularly areas like the prefrontal cortex, the medial prefrontal cortex, or the dorsolateral prefrontal cortex. And we think that they also modulate these kind of functionally connected areas of the brain known as the default mode network. So this sort of neuroplasticity or modulation of key areas of the brain that we think are linked to some of these psychiatric and potentially neurological types of illnesses as well involve the ability to unlearn and relearn, or for the brain to adapt to different types of circumstances. And this is important for healthy brain function at baseline. And this is perhaps more hypothetical, but when you have a little cut on your arm, there are innate mechanisms that the body has to heal that cut on your arm. So it's been postulated that the brain, or psychologically, must have some type of innate healing mechanisms as well. So perhaps psychedelics are triggering these types of mechanisms and giving the psyche a chance to undergo healing. And ketamine, psilocybin, and MDMA are all neuroplastogens, or display neuroplastogenic types of effects. And I think my take home here is this neuroplasticity, because you're talking about unlearning and relearning, really have a broad potential for different types of therapeutic applications. Certainly some of the psychiatric conditions like depression or PTSD are kind of front runners, but psychedelics also have some data emerging for things like substance use disorders. And if you go to clinicaltrials.gov and start plugging in some of these psychedelics, then you'll come up with indications that are neurological, like migraine or traumatic brain injury. So there's a huge amount of interest in this kind of neuroplastic potential of psychedelics and what that may mean as far as translating into treating different types of illnesses. So I mentioned the default mode network on a previous slide, and I'm just going to circle back to this really quickly. Again, it's a functionally connected set of brain regions that involve parts of the prefrontal cortex. So this is one of the most recently evolved areas of the brain, and parts of the limbic system, which is a much more ancient area of the brain, and we think primarily linked to feelings or emotions. So acutely, the psychedelic experience tends to diminish the activity of the default mode network, and this is kind of correlated with a feeling of being reset. And I don't particularly like analogies between computers and our brain. It's like, oh, you just push the reset button and the computer sort of like fixes itself. But subjectively, many people feel like there's a neural sort of resetting mechanism that occurs from psychedelics, and it's correlated or associated with a diminishment in this default mode network's activity. So MDMA and ketamine also modulate the DMN, or the default mode network's function. However, it really is things like psilocybin or LSD, DMT, and ayahuasca. So some of the tryptamine, serotonergic tryptamine types of psychedelics that really have the most research as far as their ability to impact and change the default mode network's function. Is there any overlap between serotonergic psychedelics and dissociatives like ketamine? There's a wonderful article here in Nature Reviews Neuroscience. It's from 2010. It's from Franz Wallenweider and colleagues. And it turns out that, yes, potentially there may be some overlap or convergence in their mechanisms. And it seems that whether it's via stimulation of serotonin 2A receptors or disinhibition of GABA interneurons, they both converge in their ability to upregulate or increase neurotrophic factors like brain-derived neurotrophic factors, particularly in these cells of the cortex, or layer 5 pyramidal neurons of the cortex. What's the difference between some of the subjective effects of a serotonergic psychedelic and a dissociative psychedelic like ketamine? And I will say that this graph here, this 5-domain altered states of consciousness comparison that you see between psilocybin and ketamine is purely in consciousness. So you could also measure effects of psychedelics by looking at what they do to the body, for example, but this is really about mental states, this graph. And essentially what you see is that ketamine is much more characterized by a sense of disembodiment and perhaps more impaired control of cognition, whereas psilocybin is characterized more by audiovisual synesthesia, or sort of a mixing of sensory inputs, vivid types of imagery or kind of hallucinogenic types of imagery. But they both converge in that they have this kind of experience of unity or a feeling of oneness associated with them, and kind of a changed meaning of perception. So again, this changed meaning of perception is probably pretty important in the sort of feelings that people get with psychedelics of, I had an insight, I had a realization, I had an epiphany. So essentially allows them to see old problems in a new light, or see their life from a different type of perspective that tends to have some utility for them. Let's kind of talk a little bit about contraindications and exclusion criteria. In most clinical trials to date, this is kind of the list of conditions psychiatrically that have been excluded. And right off the bat here, I'll say that ketamine is an exception, and it seems to be a little bit different than the serotonergic psychedelics in that ketamine has been studied for bipolar depression in persons with bipolar 1 types of disorders, whereas that would essentially, at least to our modern day clinical trials, be an exclusion criteria for serotonergic psychedelic use. And ketamine, beyond being indicated for the treatment of major depression, is now also indicated, or I should say S-ketamine, is indicated for suicidal ideation when it occurs in the context of depression. So ketamine is a lot farther along than the serotonergic psychedelics as far as research goes, and we have a lot more data that it can be used in some, perhaps more serious types of conditions and circumstances than the serotonergic psychedelics. Things like psychosis and schizophrenia are broadly thought to just be exclusionary criteria for psychedelics, and there's kind of a whole body of research that looks at psychedelics as far as probes into understanding illnesses like schizophrenia further. The personality disorders, it's often kind of fine print in clinical trials, will say things like, well, any condition that impairs the ability to build trust and rapport with a therapeutic team. And some of the personality disorders classically have a lot of difficulty in forming close relationships with other people. So, these are exclusion criteria from the clinical trials, and, some of them I really, the red I really do think of as kind of contraindications. The other things I would kind of think of more as red flags that really need some exploration, planning, and thought, but may not necessarily outright preclude the person from using a psychedelic. Let's talk medical and neurological exclusion criteria. Clinical trials again, the psychedelics tend to increase blood pressure and heart rate, so they've excluded people that have uncontrolled hypertension, as well as a range of other types of advanced cardiovascular conditions from clinical studies. Particularly with psilocybin now, there are several randomized trials for life-threatening illnesses, and most of these participants do have cancer, and they essentially enroll any stage of cancer. It could be stage 4 metastatic cancer, but they've still excluded people that have a terminal prognosis or have either a CNS tumor or metastasis to the spine or brain. And some of these other things like diabetes, are things that increase the risk of cardiovascular events. And, perhaps during a psychedelic experience is a prolonged period of time where the person may not be eating much. So things like blood sugar control could become an issue. Do I think that persons with diabetes should never ever use a psychedelic? No, but I think, depending on the severity of that level of diabetes and the psychedelic in question, they really should be steered away from prolonged fasting and some of the other things that are common around different types of psychedelic experiences. So some of these conditions, there may be risk. In some of these conditions, it may be that it was going to confound the experimental design, perhaps. Things like traumatic brain injuries, they're going to exclude from trials with major depression. But as I mentioned earlier, there may be different studies that are ongoing that are interested in looking specifically at those conditions. So a grain of salt with this list, and it's just a list of exclusion criteria more than a say-all, end-all, contraindications written in stone type of list. So I'm going to go through and talk about the pharmacology of these kind of three frontrunners now, ketamine, Mdma, and psilocybin. And the kind of formula that I'm going to go through for each one is kind of talking about the mechanism of action a little bit. And in pharmacy terms, we call this pharmacodynamics. So what the drug is doing to the body at its supposed target or site of action. I'm going to talk about the metabolism of the drug. So this is more a pharmacokinetic type of perspective, or what the body is doing to the substance. And with these two pieces, the pharmacodynamics and the pharmacokinetics, we can then have a pretty solid idea of what some of the drug interactions for each substance may look like. So ketamine chemically is an aryl cyclohexamine. It's an analog of PCP or phencyclidine. I mentioned that its primary action is to block glutamate receptors or the NMDA receptor. It does interact with a variety of other targets in the brain and probably opioid neurocircuitry. There's some research there, and it's not a mu agonist like other types of opiates are, but it seems to modulate opioid neurocircuitry with some more minor effects at some of the monoamines like dopamine, norepinephrine, serotonin. It's available as a racemic formulation. So if you hear someone just say ketamine, or maybe they're using like an old school brand name like Ketalar, they're essentially talking about racemic ketamine, which means that it's available in R and S. Chemicals come in mirror images of each other, and these mirror images can have differing types of pharmacology. So when someone says ketamine, they're talking about racemic or RNS ketamine, whereas the one that's been approved by the FDA to treat depression and suicidal ideation in association with depression is S-ketamine. So it's just a single enantiomer, and there is another company out there that's looking at the pharmacology and clinical development of the R enantiomer. So ketamine differs a lot depending on the route of administration, because the routes of administration have different bioavailability. And essentially, intravenous is 100% bioavailable by definition. If you're giving 100 milligrams intravenously, 100 milligrams is going into systemic circulation. Whereas when you give drugs by other routes of administration, not all of it will make it into systemic circulation. So things like intranasal and intramuscular still have pretty good bioavailability, whereas the oral bioavailability of ketamine is really quite low. And there actually are clinics that are now using oral ketamine not to create a dissociative type of effect from ketamine, to create more of a lucid, dreamy type of effect, and then they go ahead and perform a type of talk therapy. But what you see with the data that really demonstrates its benefits in depression is usually either an intravenous infusion of 0.5 milligram per kilogram over 40 minutes, or via intranasal administration. You do have a lot of docs out there that like intramuscular because of its convenience. You don't need an infusion suite, and it's much more amenable for outpatient office use that way. So I say all this because depending on obviously what dose you pick, but also the route of administration, this is really going to affect how big of a dissociative experience you create for the person that's undergoing the therapy. Okay, so the metabolism of ketamine is primarily hepatic or through the liver, and the oral bioavailability of ketamine, as we saw on the previous slide, is quite low because there's an extensive first pass effect. And this essentially means that when ketamine is absorbed out of the small intestine, it goes straight into the hepatic portal vein, and 5 out of 6, 80 something percent of ketamine is metabolized before it reaches systemic circulation. The enzymes, or the cytochrome P450 metabolic enzymes that are most involved in the metabolism of ketamine, are CYP3A4 as well as CYP2B6. And if this sounds Greek to you, don't worry about it. But if you're following along, then you'll probably appreciate this level of detail as far as the metabolism goes. So from the sort of mechanistic perspective, or a pharmacodynamic type of interaction, we know that ketamine works on glutamatergic types of receptors, and glutamate's the major excitatory neurotransmitter in the brain. GABA is the major inhibitory neurotransmitter in the brain, and these two neurotransmitters are often balancing each other out. One of them can be metabolized into the other. So the drugs that tend to interfere with the mechanism of ketamine the most are GABAergic types of medications, things like the benzodiazepines, or perhaps other drugs that work on NMDA receptors like memantine or Namenda, I should say. And the mood stabilizer Lamictal also has a glutamatergic type of mechanism of action. Some of the atypical antipsychotics have been flagged as potentially interfering. And I will say alcohol, diminishes some of the dissociative effects of ketamine, but it actually could increase some of the sedative effects of ketamine and or make things like vomiting more likely to occur. So alcohol and ketamine can be a very dangerous combination overall, because the person can end up being, profoundly sedated and very, very nauseous, and that creates a type of aspiration risk. The real upside of ketamine is that it's compatible with a lot of the first-line psychiatric therapies that persons with conditions like major depression could potentially be taking, things like the SSRIs or SNRIs, mirtazapine or bupropion. And it's also compatible with some of the first-line mood stabilizers like lithium or valproic acid that persons with bipolar conditions are taking. So it's really nice because ketamine is compatible with a lot of different psychotropic medications. And so the person may not need to make big changes in their medication regimen to undergo a type of ketamine therapy or ketamine-assisted therapy. From the pharmacokinetic or more metabolic side of things, ketamine is metabolized by CYP2B6 and CYP3A4, so drugs that affect those enzymes' functions are going to change the metabolism and change the systemic exposure and subsequent effects that ketamine has. So things that block those enzymes are going to increase the oral bioavailability of ketamine and create higher serum concentrations and more of an experience. Whereas there's some things out there that are inducers, or they kind of rev up or increase the liver's metabolic capacity, and that would decrease the bioavailability of ketamine and reduce the types of effects. So, with pharmacokinetic interactions, it really depends how well quantified they are overall and how predictable it is, but they're not necessarily contraindications as far as oftentimes as pharmacists we're thinking about, well, are there empiric dose adjustments that we would make when we know these interactions are there and exist? Let's go ahead and talk about MDMA now, or 3,4-methylenedioxymethamphetamine. As far as the mechanism of action, I said earlier in the slide deck that serotonergic psychedelics work primarily through stimulation of serotonin 2A receptors. And for the next one we talk about, psilocybin, that really is primarily what it's doing. MDMA seems to have a mechanism of action that's a little bit more complex. It does bind serotonin 2A receptors, and that probably is responsible for some of the psychedelic or really emotionally expanding types of effects that MDMA has. But, MDMA is structurally an amphetamine. Amphetamines tend to release monoamine neurotransmitters, so it releases serotonin, norepinephrine, and dopamine. And, I think a real distinction I'd like to make for the audience is that things like methamphetamine or D-amphetamine, dextroamphetamine, they really release almost exclusively norepinephrine and dopamine. They have very little action at serotonergic synapses and neurons overall, whereas MDMA primarily releases serotonin and to a lesser extent releases norepinephrine and dopamine. So I'd like to think of MDMA pharmacologically as a serotonergic amphetamine. MDMA also has some very interesting neurohormonal types of effects. It can release the neuropeptide oxytocin, which is involved with social bonding and attachment, feelings of closeness. And it also releases antidiuretic hormone or vasopressin. So this is MDMA at serotonin synapses, and particularly I'm picking the serotonin 2A synapse, and you see that MDMA releases serotonin by blocking this enzyme over here. See if I can bring my cursor over. Go. Through VMAT2, and it releases serotonin by reversing the flow of the serotonin reuptake pump. So this is called carrier-mediated release. Normally that reuptake pump sucks serotonin from the synapse back up into the presynaptic nerve terminal, but under MDMA, this directional flow is released. So MDMA does increase intrasynaptic serotonin, and beyond that is also able to bind serotonin to a receptor. So this probably plays into safety to some extent. And in clinical trials, they're using pure MDMA in moderate doses. So you're not seeing things like stimulant toxicity or serotonin syndrome from too much serotonin. But because MDMA releases serotonin, there is a point where MDMA is going to become physically toxic. As far as metabolism of MDMA, again, it is primarily hepatic, although the enzyme that is most involved in the metabolism of MDMA is CYP2D6. And differences in CYP2D6 can happen genetically, and this could influence the person's MDMA experience. However, MDMA is able to inhibit its own metabolism. They call it a CYP2D6 autoinhibitor. So although the kind of person's underlying genetic profile at CYP2D6 does play a role overall, it's a lesser role than other substances that are metabolized by CYP2D6 because functionally, phenotypically, MDMA is going to create a poor metabolizer status for everyone at CYP2D6. Lots of other CYP enzymes involved in the metabolism of MDMA, and there are some substances out there that block several of these enzymes. So Wellbutrin, bupropion, blocks CYP2D6 as well as CYP2B6. So there is a significant pharmacokinetic interaction there. But the ones that seem to be really toxic in combination with MDMA are some antiretroviral medications, things like ritonavir or cobicistat, that are sort of pan-CYP inhibitors, that they block lots of different liver enzymes. And there have been cases of drug toxicity and death combining them with MDMA. Okay, so drug interactions, pharmacodynamically, SSRIs have a pretty significant interaction potential with MDMA. They block the serotonin reuptake pump, meaning they block the ability of MDMA to release serotonin, and you get greatly diminished types of effects. So this is probably going to be a big hurdle for MDMA-assisted therapy because a lot of people with depression, or I probably should say PTSD, are going to be taking those types of medications at baseline. Because MDMA increases intrasynaptic serotonin, it's going to be contraindicated with monoamine oxidase inhibitors, and that's going to be a very dangerous recipe for serotonin toxicity or serotonin syndrome. Lithium has been flagged with serotonergic psychedelics as also increasing the risk of either serotonin toxicity or seizures. The benzodiazepines kind of globally diminish effects of psychedelics. And, if you start mixing MDMA with other stimulants, you could run into stimulant toxicities. I mentioned some of the pharmacokinetic interactions already. All right, Last one, ready? Let's talk about the pharmacology of psilocybin. So this is the mechanism of psilocybin, and I really should say psilocin. So let's all back up and say psilocybin is a prodrug, meaning that it's rapidly metabolized in the body to psilocin, and it's probably actually psilocin that is driving a lot of the subjective or psychedelic effects when people talk about psilocybin. So this is psilocin at serotonin 2A synapses, and you can see it's a lot less complicated than something like Mdma. It does not increase intrasynaptic serotonin, and it primarily binds directly with serotonin 2A receptors. And I personally believe this is why there's such a wide therapeutic index with psilocybin, in that it's very difficult to calculate what a lethal dose of psilocybin may be. And this doesn't say you can't overdose. You could have a psychological experience that was way too intense, but physically you don't develop serotonin toxicity, and it's extremely rare, if ever, that someone's actually lethally overdosed purely from psilocybin. It's usually more of a behavioral toxicity associated with a profound non-ordinary state of consciousness and a creation of a potentially dangerous situation when they're not in a supportive or safe setting. Metabolism of psilocybin and psilocin, I mentioned that is rapidly dephosphorylated to psilocin, and then about 80% of it is metabolized by the liver, but not those same CYP enzymes like ketamine or Mdma. It goes straight to a different type of metabolism called phase 2 metabolism, and this really minimizes the risks of pharmacokinetic types of actions with psilocin. There's not very many drugs that block or activate the effects of these UGT or glucuronoltransferase phase 2 metabolic enzymes. Very minor metabolisms by phase 1 are the CYP enzymes. Probably about 20% of psilocin is metabolized by monoamine oxidase. So as far as psilocybin and drug interaction, there's anecdotal reports, increased risk of with lithium, and lithium really is the one medication that is flagged in my mind as truly contraindicated and probably dangerous in combination with psilocybin. There's many other, like atypical antipsychotics, block serotonin 2A receptors and definitely diminish the effects of psilocin. There are other things, right, like SSRIs that, they don't block serotonin receptors. They increase intrasynaptic serotonin. And if you did that chronically or took an SSRI over a long period of time, like many patients do, perhaps this could downregulate or decrease populations of serotonin 2A receptors and result in a blunting of effects. But we have a whole lot less data available out there with SSRIs and psilocybin compared to with MDMA or ketamine. Some more theoretical things like around migraine agents, around triptan, like sumatriptan, or the ergos like ergotamine that cause vasoconstriction and sometimes rarely have vascular events associated with their use just as monotherapies. Perhaps if you added other serotonin agonists like psilocybin, maybe there would be some additive vasoconstriction, and it could create a potentially dangerous situation if they were used in combination. All right, getting close to the end, everyone. Comparative pharmacology. I'm going to go through this relatively quickly because I really want to get to the question and answer. But, I kind of have some of the leading indications bolded here. So MDMA-assisted therapy is really the front runner for PTSD or post-traumatic stress disorder, whereas both psilocybin and ketamine have been focused on treatment-resistant depression. Again, the big differences between serotonergic psychedelics and ketamine is that the depression that ketamine is able to treat is unipolar or major depression, as well as bipolar depression. So this is a huge advantage of ketamine, the serotonergic psychedelics, where that's essentially considered to be contraindicated. And ketamine has much more data in kind of more crisis types of situations where the person's experiencing significant levels of suicidal ideation. Ketamine's also the front runner as far as it is legally available. It is FDA approved as a C3 controlled substance, whereas the other two, MDMA and psilocybin, are regulated as both as illicit drugs like C1s, but also experimental compounds because they're going through a clinical trial process. This has a lot to do with kind of a dosing and subjective qualities of the experiences, and I'll leave those there for you to look at. The clinical regimen for MDMA assisted therapy in phase 3 trials is 3 MDMA sessions spaced about a month apart with therapeutic support that begins before, happens between, as well as afterwards. So I think that this would be a good place to kind of come back to Abigail's story. She was kind of saying, well, I had this psychedelic experience and it was significant for me, and I did a little bit of the integration and a little bit changed. So perhaps we should understand, psychedelics as creating the ability to change or the ability to transform. Like, again, there's this neuroplastic piece, but what a person does with that neuroplasticity is probably really critical for not only the kind of symptom reductions that could happen in the few weeks afterwards, but if you're really trying to make the results of the psychedelic experience sustainable, then there's probably going to have to do some pretty heavy duty work on the backside to realize the benefits and make them persistent. You're going to have to relearn your life. You're going to have to give up the maladaptive coping mechanisms and replace them with healthy types of coping styles. Psilocybin and depression, they've used 1 to 2 sessions spaced 2 to 6 weeks apart. Substance use disorders, obsessive compulsive disorder, 2 to 4 sessions, 2 to 6 weeks apart. So a little bit more flexibility with psilocybin. It doesn't deplete serotonin, so that there's perhaps less of a refractory or recovery period that is absolutely necessary after psilocybin, but they tend to be pretty big experiences, and people may not really feel ready to go back to the well for more a week later. They really may need longer than that and some more therapy and to make some lifestyle changes before they're really ready for their next experience. Whereas ketamine's usually used kind of in an induction round where you're doing several experiences, maybe 2 or 3 a week for 2 to 6 weeks. So somewhere between 6 and 12 treatments with ketamine initially, and then you're going to observe, kind of slow things down, and hopefully come up with either a maintenance regimen where the administrations are spaced so far apart that the person is just happy with that, or kind of the creation again of these sort of persistent and long-lasting benefits through the integration psychotherapy. All right, summarize and conclude tonight. There's different classes of psychedelics out there, and they're all rapidly accumulating evidence of benefit for psychiatric conditions. They share their ability to promote neurogenesis, synaptic plasticity, and non-ordinary states of consciousness. And these 3, ketamine, MDMA, and psilocybin, are front runners in clinical research. They focused on refractory mood and substance disorders. So perhaps this is an important piece that I didn't mention, is that they're oftentimes selecting people in these clinical trials that have not responded to traditional treatments, and that's why they call it TRD, or treatment-resistant depression. And really, I think with psychedelics, careful selection of your candidate, screening for some of the contraindicated conditions and the red flags, and exploring those red flags in depth ahead of time, building trust and rapport with the therapeutic team, and kind of managing medication regimens. Hey, I'm a pharmacist. That's kind of like what I'm most interested in, really, is kind of the management of psychotropic medications in order to make psychedelic experiences safe and effective. And then, of course, once you've kind of accessed the non-ordinary or neuroplastic state of the psychedelic, what are you going to do with that? Maybe a nice analogy to kind of finish would be like, well, psychedelics can point the direction, but it's still going to be up to the person and their therapeutic team to help them walk the path. That's all I got as far as slides. I'm going to stop sharing and open us up for question and answer here.
Thank you so much. That was awesome. And we have so many questions. We are very happy to have you here. Like I said, we even have carryover questions from other previous talks. So this is really, everybody's questions are related to pharmacology. I guess I'll kind of start where you started, talking about neuroplasticity. We have a few questions on that. Somebody is asking if neuroplasticity and use of psychedelics could help with recovering from brain damage. Similarly, somebody mentioned about how traumatic brain injury is often an exclusion criteria for psychedelics, even in the case of, like, say, PTSD. Somebody has PTSD from a traumatic brain injury. What are your thoughts on neuroplasticity and traumatic brain injuries?
Yeah.
Alex?
Yeah. So the thing with brain injuries is that it probably depends on what part of the brain was hit and how hard it was hit. So the most common types of traumatic brain injuries are going to be frontal lobe injuries, because people get punched when they have motor vehicle accidents. They're going to hit the kind of front of their face. And this is where that prefrontal cortex is. So it seems that, psychedelics can create neuroplasticity in that brain region. And there's oftentimes when people have a traumatic brain injury, they experience things like PTSD, depression, maybe perhaps just like anger, irritability, like personality changes, or some of the things that happen afterwards. At least hypothetically, psychedelics may be amenable to helping that type of population. I mentioned that they get excluded from trials of major depressive disorder or PTSD for the moment, because they're afraid that those neurological types of conditions are going to confound their results somehow. So they're really trying to create a trial with pure major depression or pure PTSD, which is obviously not really how the real world functions. This isn't just a criticism of psychedelic trials. This is just like all types of studies in medicine, is you pick a specific population to study them in, whereas I mentioned there's also trials now that are looking specifically at things like traumatic brain injuries. So trials that actually select for those. And I really hope it works, because traumatic brain injuries are something that do not respond very well to many of the traditional types of psychiatric medications or psychotropics at all. And DMT, I see like clinical trials for like stroke recovery too. And this is another therapeutic area that if you can't catch the stroke early enough and use kind of one of the clot busting types of drugs, then functional recovery can be extremely difficult and tends to be kind of irreversible in a lot of cases. But again, where did the stroke occur in the brain? How massive was the stroke? What is the level of functional impairment there? My kind of suspicion is that psychedelics will probably work for some type of neurological injuries in some regions of the brain, but to kind of globally think, well, they just cause all sorts of neuronal growth and can repair any region of the brain and any severity of injury, I'm skeptical.
Yeah, good point too about the clinical trials. I mean, unfortunately, with exclusion and stuff like that, it can be really frustrating now, but it's definitely a process and you got to start somewhere. Continuing on with neuroplasticity, I'm not sure if LSD is much different or if it's similar. Somebody asked specifically about LSD.
Yeah, so actually a lot of the sort of, at least neuroimaging that they have on the default mode network is done with LSD. So LSD definitely has the kind of synaptic plasticity of the other psychedelics. I kind of think that, when people kind of think of psychedelics in a bad rap, LSD is kind of the poster child. Acid even creates this kind of like corrosive sort of like connotation to it. And then it's also a longer experience. It's an 8 to 12 hour type of experience, where psilocybin and Mdma is more like 4 to 6. So perhaps, LSD is just a little too long for the clinic, or many therapists that, like we could get the same amount of work done in 4 to 6 hours. So, maybe it's just not like a front runner as far as clinical research right now, at least in like patient populations. But as far as like neuroimaging and as a probe to understanding what psychedelics do, LSD is used quite often.
Moving on to microdosing, because of course, perfect question for psychopharmacologists talking about psychedelics. Can you talk about psilocybin and microdosing and how that compares to like a one-time large dose?
Yeah, so microdosing is essentially a practice of using very small doses of psychedelics on a semi-chronic or consistent type of basis. So they think of microdoses about 5 to 10% of what you would consider a full dose. And instead of using it very intermittently with this model of, supervised accompanied support, microdosing is often used maybe 3 times a week on alternating days, or some microdosing regimens will say things like 4 or 5 days on and then a couple of days off. And there's lots of surveys out there where people are saying, yes, microdosing is wonderful. So far the controlled research has not been very impressive at all. And some of the most methodologically rigorous studies have suggested that microdosing is probably a placebo type of effect. So the jury really is out in my mind as far as the efficacy of microdosing, whereas the macrodosing with therapeutic support is literally producing unprecedented results as far as what we've seen in psychiatry. Now, I'll add that psilocybin binds serotonin 2A receptors. It binds other serotonin receptor subtypes, including the serotonin 2B receptor, which is a receptor that has been linked with chronic drug toxicities like valvular heart disease. There's been several drugs that have been pulled from the market over the years because they bind with serotonin 2B receptors and they can cause heart valve thickening. So beyond the jury being out on the efficacy of microdosing, I think the jury is also out as far as the chronic safety, or so what does it mean to ingest small amounts of psychedelics on an almost everyday basis. That's something that we don't have much good research about, and some pause for concern or precedent from other substances.
Sort of along the same path of like that sub-psychoactive dose, it makes me think, in terms of mystical experiences mediating some of the beneficial outcomes. Somebody asked, can you discuss why the human brain is structured to have a mystical and a dissociative, type of experience? And, what do you think about sort of like this mediating element of the mystical experience to these outcomes?
Yeah. Wow. The first part of the question is literally one of the most fascinating questions that there is, really, in my mind, or is kind of like, why is it that if we just tap on this serotonin 2A receptor and put you in a safe and supporting environment where perhaps there's a little bit of intention and ritual employed throughout it, then there's a really good chance that you're going to have a bona fide mystical or religious type of experience. And, I think to me, it suggests that, well, maybe humans have co-evolved with psychedelics for a long time, or perhaps it just means that there are elements of how we are created that means that, spirituality is part of it. And, it's the idea of spirit and science, oil and water, they just don't mix so well. And, this is essentially why I call our website Spirit Pharmacist is because there is underlying biological types of mechanisms that involve spirituality and spiritual experience. And there's plenty of surveys out there that many people, 25% of people have some type of spontaneous mystical experience throughout their life, particularly near-death experiences can elicit these types of effects. Different religious practices and traditions like prolonged fasting, is also, notorious for kind of creating, these types of states. And, do I think the mystical experience is the mystical bullet? And, that is what is driving absolutely all benefits? No, not really. And I mean, look at Abigail's story, right? It was kind of like, well, maybe there are some spiritual effects of these substances, but it was really encountering all of my traumas and feeling into all of the different areas of my life and facing all of those things that allowed me to do the integration work and get to the place I am now. And so I personally think the trajectory of a psilocybin experience is before you meet God, you meet yourself. And, if you've got a closet full of skeletons for the last 20 or 30 years, those first few hours of the experience could very well be quite intense and quite challenging emotionally, psychologically, physically, right? But usually at some point in that experience, given they're in a safe and supportive setting, the clouds part and there are some different, very spiritual types of effects that happen too.
A very interesting question indeed. So I will be very curious to see what the science continues to uncover on that one. Can you comment on the rate of psychosis? And then somebody also asked about hallucinogen, persisting perceptual disorder, and things like that. I know that they're somewhat rare, but definitely concerning. So thoughts on that?
Yeah, so it's really difficult to comment on the rate, right? Because this is not something that is very well measured out there. And I think a lot of the times when a psychedelic does precipitate a type of psychosis or perhaps mania, it usually is in an individual that has either had those things before or is potentially predisposed to them. So thinking about onset age ranges of things like schizophrenia or bipolar disorder, they're usually teens through perhaps early 30s, right? So perhaps these candidates, need some additional screening or counseling around these things. Things like ayahuasca, have like observational studies, and they'll show that, well, people in their late teens and early 20s that drink ayahuasca do not have recurrences of schizophrenia that are higher than the general type of population. So this is an area that I personally would like to see a lot more research into, because it's a really common question. It's like, okay, I have a bipolar condition. Does that mean I can never, ever use a serotonergic psychedelic? And it's kind of like, well, they're considered contraindicated because they could precipitate those types of states, but so can SSRI monotherapy, and so can cocaine, and so can withdrawal from alcohol, and so can triple espressos at 9 p.m. when you're under a lot of stress during finals week. So I think the jury is kind of like out as far as like, okay, we know that there is this risk and we know that it is a rare type of risk overall, but how does it stack up against other types of substances or circumstances that we know also have these kinds of risks to them? And what are the real factors, right? Is it a very high dose in an uncontrolled setting has a much higher risk of that occurring than someone that's prepared adequately for what they may encounter, the dose is moderate and the environment is controlled. I think that these factors probably make pretty big differences in the safety of the experiences overall, and maybe what some of the post-use effects are as well. And I'll say really similar things about HPPD as far as that we only have observational research that says it's rare. And yeah.
You got me with the triple espressos at 9 p.m. on finals week. But yeah, no, it's so true. I mean, even being a nurse and working inpatient, things like steroids can, trip people into
right. Yeah, you see adverse psychological reactions to all sorts of things out there. So it really does beg the question, is like, well, what is the risk of these things versus others? And there's, to my reading, it's pretty extensive. I can't find the answer.
The risk versus the benefits even.
Yeah.
In terms of like anti-inflammatory properties of psychedelics, are there any indications for any kind of autoimmune disorders? Anything like that on the horizon?
I haven't seen any clinical trials planned that address psychedelic assisted therapy for a specific type of autoimmune condition. There are some review articles out there that talk about the anti-inflammatory properties of psychedelics in the context of autoimmunity and how that could I mean, it's like a postulated type of thing rather than well known. There are different anecdotes. There's a book out there by Dr. Joseph Tafur called Fellowship of the River, where he talks about people that have things like inflammatory bowel syndrome or Crohn's disease that go down to the Amazon and they get put on a pretty strict type of jungle diet and use ayahuasca over a period of months, and a lot of their symptoms tend to kind of clear up. And a lot of autoimmune conditions are highly, highly associated with psychiatric conditions as well. So it is something that, well, maybe there is some type of psychosomatic component to some people's autoimmune types of illnesses, or, perhaps in some ways it is all the immune system. That the immune system, to me, its most basic function is to tell self from non-self. It's supposed to recognize viruses, fungus, cancer cells even, right? And kind of get rid of them. And autoimmunity is the body attacking itself. Whereas, I think of, what is the sort of ego structure of my brain? Like, what's its function? Well, it tells self from non-self. It tells Ben from the rest of the world. So if psychedelics can somehow change this relationship of self and non-self, maybe. But that's very, I think that we're a few years away from really understanding if psychedelics have any potential to significantly impact a lot of different types of autoimmune conditions. Pretty speculative right now. Yeah.
Yeah, I mean, I was thinking, I know that there's a trial for mild cognitive impairment, like depression and mild cognitive impairment. And I was like,
Yeah.
it's almost perfect that there's been so much research on the depression, because then they have that sort of as an indication. And then it's like also looking sort of at the neuroplasticity and like the autoimmune, things that may be underlying, dementias and things like that. So it's like,
Yeah.
you need to slowly segue so you can kind of get to different questions. But it's all very interesting. Back to maybe some more like basic pharmacology stuff. Do you suggest a washout period of medications, and how do you usually navigate that, or how would you usually suggest people navigate that with different other psychoactive medications or psychopharmacology?
It really depends on which psychotropics they're taking and which psychedelics that they want to use. If they're thinking of, I have PTSD, I really want to get to a clinical trial with the Mdma assisted therapy. Well, they're going to require you to stop your SSRI for that. And there's some pretty good data suggesting that SSRIs block the ability of Mdma to release serotonin. So it just kind of seems that from a lack of efficacy perspective, that would be a contraindication. If the person really wanted to go in that direction, that they would have to consider tapering and washing out that kind of medication. Whereas other circumstances, it's a lot less clear. Like I mentioned, psilocybin, for example, as some people report, it diminishes their antidepressant, like an SSRI, diminishes the effects of psilocybin. Some people report the effects are preserved and they get some pretty good therapeutic types of qualities out of psilocybin, even while taking an antidepressant. So a little bit of data has been emerging and coming out around this, and it's not very conclusive. It's very short term. They give healthy people SSRIs for a couple of weeks. And it's like, well, it takes 4 to 6 weeks for them to even work. So it's sort of like, how is this going to answer our question overall? But at least in those short-term types of things, they have found that the effects of psilocybin, or at least the sort of positive or mystical effects, tend to be preserved. So this is essentially I think where, kind of cookie cutter psychedelic therapies, let's look at the chart and require everyone to stop their antidepressants to use psilocybin, may get us into a little bit of hot water, because some people get benefits from SSRIs. Some people don't really want to stop their SSRIs. Some people are very sensitive to withdrawal effects of SSRIs, and that could cause a type of clinical decompensation that puts them in a crisis before they're even able to get to that experience. Whereas some people haven't been taking them very long and either got side effects or didn't really get the benefits that they were hoping for, don't really feel attached to it overall, and are really looking for a different type of therapeutic alternative. And it makes a lot more sense for them to try and taper and discontinue than, someone that's, feeling really low at baseline and is predicted to feel a whole lot lower if you try and stop their medications. Maybe steer them towards something like ketamine. Can we get your depression a whole lot better with ketamine? It's compatible with your SSRI. And once you're feeling a whole lot better, we can revisit the question whether you really want to try and taper and try a different type of psychedelic or not. So depends on the med, depends on the question, depends on the person's life circumstances, probably the best answer.
Yes, it's all very complex. So you talked about MDMA, ketamine, psilocybin, another psychedelic that you didn't touch on, but if you can comment on the use of Ibogaine for addiction. I believe that it's been used for alcohol addiction. I'm not sure about that. Somebody mentioned opioids, and then another person had a general question about using psychedelics for opioid withdrawals.
Using psychedelics for opioid withdrawals or specifically Ibogaine?
Two questions. First one, somebody wanted to know about Ibogaine and opioids treatment for addiction. Mm-hmm. And then the second one says psychedelics in general and for opioid withdrawals.
Yeah. Well, Ibogaine is a psychedelic that is, it seems from all of the preclinical and the, very kind of limited amounts of observational data that's in the literature, that it is really potently anti-addictive. There's quite a bit of preclinical data out there talking about upregulated GDNF, or glial-derived neurotrophic factor, which seems to really dry up cravings for alcohol in a lot of people. Ibogaine's working on nicotinic receptors that are involved in things like smoking, but it probably primarily modulates opioid neurocircuitry and tends to have kind of a resetting effect to the opioid system. And Ibogaine can detoxify people from short-acting and probably some of the more naturally occurring like opiates, things like codeine, heroin, morphine, probably works a little bit better than some of the synthetic ones like fentanyl. And it's actually going to be contraindicated in people that are taking long-acting opioids like OxyContin, methadone, buprenorphine, because of this resetting effect and, essentially just a really dangerous situation where they could get into like respiratory depression. So Ibogaine, really potently anti-addictive, not very much clinical research happening because it has real significant QTC prolongation to it and risks of things like ventricular arrhythmias, torsades de pointes, and just fatal types of cardiotoxicity. Bradyarrhythmias have occurred with Ibogaine as well. And it's just an extremely long-acting type of psychedelic. It's between a 12 and 24-hour type of experience overall, and it's not notorious for pleasant effects, right? So I still think that we should be interested in developing it clinically, particularly for opioid use disorder or things like heroin use disorder, things like cocaine use disorder, where either stimulant use disorders, there's just no FDA-approved treatment options at baseline. And opioid use disorder, we're just in a public health crisis as far as opioid use goes. And we know that opioid use disorder is a really fatal type of disorder too, because of the kind of overdose risk. So to me, when I'm thinking about using a substance that has significant risks in of itself, like Ibogaine with this cardiotoxicity, there better be a real significant benefit or payout to be realized from that as well. And so perhaps for some more severe kind of addictions, the risk-benefit ratio is there, and with things like telemetry monitoring and crash carts available, that there is a path forward, but not much research happening with it, particularly in the US.
Yeah, I was going to say I'm really not as familiar with Ibogaine, but sounds like there's a lot there. So you're right. It's always worth the investigation. On the similar line of addiction, Can you comment on how psilocybin can help with smoking cessation?
Yeah, so I think that it kind of goes back to like there probably are some inherent types of neurochemical effects of the tryptamines like psilocybin that are anti-addictive, and particularly it seems alcohol use disorder. There's many people either in clinical trials or either in anecdotal surveys that will kind of report that, God, I was just so sick of myself drinking all the time, and I ate a handful of mushrooms one evening and I realized that I shouldn't do that anymore. And then they just reduced the amount, or they were able to stop drinking. So there may be some inherent anti-addictive effect, but I personally think that it's more, people give up addictions when they're ready for change. And this is just it, is they're selecting people in clinical trials that are motivated and ready for change. So I think that the psychedelic is wonderful in perhaps resolving ambivalence. Some days I want to stop, some days I'm not so sure, right? Or I know I want to stop, but I just don't really I just feel like I need an intervention and some accountability and therapeutic support and structure and, some chemical help as far as drying up my cravings for cigarettes or alcohol. But I think that it's kind of, they have this, small clinical trial, right, of tobacco cessation and psilocybin. And I don't know the exact numbers. I mean, there's 12 participants, and 7 or 8 or 12 of them have a pretty good outcome. Like they stop smoking after 6 months. And so you see it quoted everywhere that 75% of people that use psilocybin just stop smoking cigarettes. And I believe that, again, if you're picking people that are highly motivated and put them in the structured clinical program, and you might get those results. But anyone that's been to a music festival where a lot of people are ingesting mushrooms, there's a lot of people that are smoking cigarettes while eating mushrooms, right? So it's not quite as simple as, okay, mushrooms just stops the addiction, right? I think that there has to be some level of intrinsic motivation, and then I think the sort of therapeutic structure that is focused on addiction recovery that's paired with are probably the things that really make the differences. And I'm looking forward to like a much larger trial, right, with like a couple hundred people in it or something like that to like truly kind of understand it a bit more. It's a pilot study right now, I think.
Yeah, no, I agreed. I know which study you're referring to, and the results are interesting, but you're right. I mean, you really have to look at the rigor of the study, and they definitely need more research on that. So to be determined. So somebody asked, when you refer to lithium as a contraindication to MDMA and psilocybin, does this apply to lithium carbonate only or orotate as well?
Oh, it probably is mostly lithium carbonate. So lithium orotate is like an over-the-counter supplement, and usually comes in 10 or 20 milligrams of lithium orotate, which to my calculation, like some counties have lithium in the drinking water in it. So a lithium orotate dose of lithium is probably somewhere between 3 and 5-fold what you find in like a county's like drinking water if it had in there. So the dose is pretty darn low overall. Whereas lithium carbonate is hundreds of milligrams. It's a different salt form. You're talking a couple orders of magnitude, like 100-fold, like increase over something like drinking water. Lithium has a half-life of about 24 hours. Okay? So even if you're taking lithium orotate, I haven't heard of people taking lithium orotate having withdrawal syndromes and things like that. So if you want to be on the safe side, you could hold your lithium orotate for 3 days, and most of it is going to be gone from your system, and you're not really going to have more in your system at that point than what would be in a cup of drinking water if it was in that county's water. So I tend to think of, okay, lithium orotate, no, that's probably not what they're talking about in these anecdotes where seizures occurred. It's probably more 6 to 1200 milligrams of something like lithium carbonate for a bipolar condition rather than a supplement that a person is taking.
So are there any studies looking at the combination of MDMA and cannabinoids?
Not that I'm aware of.
along the lines of MDMA and other substances, if MDMA and psilocybin don't share a metabolic pathway, then why might MDMA potentiate the psilocybin experience?
Well, they don't share a metabolic pathway, but they share a pharmacodynamic pathway in that both of them stimulate serotonin 2A receptors, and MDMA increases serotonin neurotransmission as well as dopamine and norepinephrine. So I think from the pharmacodynamic perspective of things, there's a lot of potential for synergy or overlap between the substances.
In particular with combining psychedelic substances, so somebody is giving the example of psilocybin, LSD, and MDMA. Any comments or observations sort of maybe elaborating on that in terms of like maybe therapeutic or research uses of combinations?
Yeah, I haven't seen any clinical trials that are planned as far as like combinations of these things. I'll say that in recreational settings or environments like music festivals, combining MDMA with LSD or MDMA with psilocybin is not uncommon at all. I haven't found much in the way of anecdotal literature that really supports that combining them increases the physical risk so much as far as, having cardiovascular events or things like that. But depending on the doses that you use and the timing of it, right? Like if you wait 4 hours after using the LSD to take the MDMA, then the LSD is already peaked. So, it's probably more like a continuation of that experience versus if you take them both at the same time right at the beginning and use high doses, you could get in places that are just way too psychologically intense and just not really what the person needs as far as their experience. So I'll say that for the moment, those combinations are kind of psychonautical, and there's not really much in the medical literature discussing either if that somehow improves the efficacy or if that somehow introduces safety risks.
Yeah, that makes sense. How about research on psychedelics for the treatment of ADHD?
Not a whole lot so far. ADHD is actually one that comes up quite a bit in surveys of microdosing. So not controlled research, right? But it's like surveys, like anecdotally, people will talk about because LSD stimulates serotonin 2A receptors and dopamine 2 receptors. So it tends to be a little bit more energetic and stimulating than some of the other types of psychedelics. And essentially the world of kind of like biohackers or like neurohackers are very interested in using low doses of LSD to like enhance cognitive faculties and things like that. So, but not much in the way of like controlled research, no. And there's different theories out there, right? Like the idea of like psychedelics may be helpful, really helpful, like psilocybin for like organizing types of conditions. So things that are more like, okay, a really rigid depressive rut, or the kind of rigidity of things like obsessive compulsive disorder. Maybe the sort of breakdown in the default mode network allows this kind of loosening of thoughts and beliefs that can be really helpful for those types of conditions, whereas ADHD is more of a disorganizing type of condition, and maybe they won't be that helpful there. But until you test it in a clinical trial, I don't really want to say that they wouldn't be helpful for that kind of condition, but I can't point to anything right now definitively and say like, oh yeah, there's that shows that there's really something going on.
Yeah. Maybe the last question, we're getting close to the end here. Somebody asked about regarding ketamine, are there any studies on the epigenetics dosing?
Maybe, honestly, I'm not sure on that one as far as like quoting epigenetic studies with ketamine off the top of my head.
Somebody also specifically asked if there is a contraindication with pituitary tumor?
Well, I mean, they've essentially excluded all CNS tumors so far, right? So from that perspective, it's sort of like, okay, I don't know if they would be a candidate for a clinical trial. I had a talk with a neurologist recently that was planning a study in type of glial cell like brain cancer. It wasn't like a pituitary type of thing. I think it would sort of depend to me as far as like, well, how active is the pituitary tumor and sort of like what are the sort of overall effects that it's like having on the body. Like one I don't even think I put on the exclusion criteria slide was like ectopic tumors, right? So if you have a tumor that is secreting epinephrine and the blood pressure is really through the roof and they have like a bunch of adrenaline pumping through their system all the time, it's like, well, maybe that wouldn't be a good idea to give them a psychedelic for that type of person. So I don't know if pituitary tumor necessarily just sounds like, oh, you should never do that, but maybe there's something, I'm not an oncologist, I'm a psychiatric pharmacist. Maybe understanding more about the status of that cancer overall would be necessary.
Yeah, that makes sense. So for the last couple minutes, do you have any last comments that you want to make? Any take-home messages for our attendants?
Well, I think again, like thank you to Penn Nursing for putting on this event series, and thank you so much for the opportunity to speak. And I really have enjoyed like a lot of these questions that we've gone through as well. And it may be early days for a lot of these things that we're talking about as far as neurological conditions, autoimmune conditions, microdosing for all of these conditions. But it really seems like there's enough out there definitely with ketamine and with MDMA and psilocybin and, probably, things like ayahuasca and Ibogaine and short-acting inhaled tryptamines. We didn't even touch on those, like 5-MeO, DMT, or NN DMT, that are essentially all being studied intensely at this point in time. And, you are free to take this information and make up your mind about it, whether you think it's a good thing or whether it's a bad thing. I'm not really here to try to convince you one way or another. I just think that many people for a long time have been very close-minded to the idea of non-ordinary states really being able to have any type of benefit associated with it. And there's a huge stigma there. There's a huge stigma around the use of an illicit substance or an illicit drug. There's a huge stigma with mental health conditions in general. So this whole thing is really an area that I would encourage the skeptics to kind of suspend some of their judgment, and when they start getting questions from their patients about it, right? Because your patients are probably going to start asking questions to have an articulate response and maybe some places to point them to as far as resources or help, because most of them, if not all of them, are really like Abigail, where they're suffering, they want to get better, and they are reading headlines in the New York Times. They're reading best-selling novels about this kind of stuff and coming to the table serious about doing the sort of therapeutic work that comes alongside them. And I don't know, I just sincerely believe that humanity deserves these opportunities. And I'm so looking forward to the days that I can update my slides and just have these be legal substances, and we can kind of get rid of the disclaimers that say we're talking about illicit and experimental compounds. And I think it's quite near.
Yeah, I mean, I couldn't agree more. I definitely think, like, as this conversation has gone on, we've realized it is complicated and there's so much science that needs to be done, but I'm glad that, people are opening up about it, because all very fascinating, and it could really have, a great impact on people. So we're lucky to have you here, who's an expert and who is actually able to answer some of these questions. So I thank you very, very much for your presentation and for hanging out with us and answering these questions. So that's going to wrap up our Q&A session. Big thank you for joining us tonight. Definitely, I know this was a super informative and really, really interesting experience for all of our attendees. Just another logistical thing, to all the attendees, you're going to be receiving an email that will include the recording of tonight's session, some resources that Dr. Malcolm will recommend for us, and then information about nursing continuing education credits, and of course a feedback survey. And we really encourage you to share your feedback. We're really striving to improve this series, especially as we consider future psychedelic learning opportunities. The next session of the series will be the current landscape of psychedelic medicines, and that will be on Wednesday, March 2nd at the same time from 6:30 to 8 p.m. Just a reminder, you do need to register for each session individually, and we encourage you to register no matter what, even if you can't make it, because then you'll just get the recording and you can watch it another time when you're free. So thanks so much to everybody. See you next time.